A very good afternoon to one and all. At this outset, I thank my HOD Dr. Devi Meenal and my Chief Dr. Gopinathan for providing me this opportunity. So here we go. This is my first case. I have a set of 15 questions. I'll be giving clues and trying to figure out the diagnosis with this. So here we have a case of a middle-aged woman with chronic cough and dyspnea. There was no history of asthma. There was no signs of infection on clinical and lab investigations. Anybody? Diagnosis? HSV. So what is the pattern of, what is the pattern seen here? HRCT pattern? Mosaic. Yeah. So how do you go about mosaic attenuation on a CT? So first look for the pulmonary arteries, whether it is dilated or not. So if the pulmonary arteries are dilated, it's likely to be pulmonary hypertension. Then look for the peripheral vessels. If the peripheral vessels are pruned or it is thinned, it is due to oligemia or chronic pulmonary thromboembolism. Then we have small airway disease. So how do you figure out small airway disease? Take an expiratory CT and confirm with the air trapping, and then you go with small airway disease. Then any other differential? Constrictive bronchiolitis, where you have bronchial thickening and nodules, due to which you see hypoattenuation. So if I give you another clue, that is it is a pre-neoplastic condition, which you are seeing here. So it is basically a Aunt Minnie spotter. If you know this, you won't forget it. So it is a case of diffuse pulmonary neuroendocrine cell hyperplasia, where you see mosaic attenuation due to the presence of constrictive bronchiolitis and small nodules which are scattered diffusely in both lungs. So the differentials for this could be due for the multiple nodules like metastasis and granulomatous diseases, and for mosaic attenuation, the DDs are small airway disease and pulmonary hypertension. The complications for this disease are respiratory failure, and as I already mentioned earlier, it is a pre-neoplastic condition. It can progress to full-blown carcinoid tumor. So here is another case, a 30-year-old female with dyspnea. It is also a spotter. Anybody? Diagnosis? So in this chest X-ray, you can see a well-defined opacity in the right lower zone, and also you can see another opacity in the lingular lesion or the retrocardiac region, and superior to it, you can see a linear vascular structure supplying it. Differentials or diagnosis? Anybody? So this is a CECT picture. You can see a well-defined mass where it is supplied by a feeding artery and early draining vein. Now, pulmonary AVM. So here are a few imaging features and classification of pulmonary AVMs. So pulmonary AVMs are classified based on the number of feeding arteries supplying it. It could be simple, complex or multiple. Simple pulmonary AVMs are those where you see a single feeding artery, and there can be more than one draining vein. Usually these draining veins are 1 to 2 mm larger than the feeding arteries. And in complex types of pulmonary AVMs, the lesions are usually supplied by more than 2 feeding arteries, and they have 1 or 2 draining veins. And multiple or diffuse pulmonary AVMs are where you can see multiple pulmonary AVMs diffusely scattered in both lungs, and this is seen in hereditary hemorrhagic telangiectasia or Osgood-Weber syndrome. So the major complications of this problem is that there will be right to left shunt. Due to this, the patient may develop chronic dyspnea, and apart from that, the major deadly complication is that if the feeding artery is thrombosed, there is high chances of paradoxical embolism. That is, usually we see pulmonary embolism when there is a DVT, but here when this artery is thrombosed, the thrombus gets into the left-sided circulation and goes into the systemic vessels, and the patient can present with stroke and hemiparesis. So it is important to treat this condition with either coiling or balloons. So here is my third case. So a middle-aged man with history of weight loss and new onset diabetes. So CECT chest and abdomen was advised. The abdominal findings, anybody? It is a spotter. Huh? Sausage-shaped pancreas with peripancreatic halo. Yeah, it is autoimmune pancreatitis. Associations of autoimmune pancreatitis. If I say the IgG levels are elevated in this patient, so autoimmune pancreatitis is a chronic pancreatitis and it has an association with IgG4 disease. IgG4 diseases are recently been asked regularly in the examination, so please have a look at it. So IgG4 levels are elevated and intrapulmonary IgG4 disease is a very new entity and like any other every case in chest, it is either consolidation or nodular consolidation. So it is important to correlate clinically. So what we are here seeing here is a nodular consolidation here. So intrapulmonary IgG4 types are classified into 4 types: solid nodular, round-shaped ground glass opacities, alveolar interstitial thickening, and bronchovascular. So in solid type, you see a solid nodule with spiculations due to the surrounding inflammation and fibrosis, and round-shaped ground glass opacities where we can see multiple areas of ground glass opacities which are well-defined and rounded. And in interstitial type, we can see honeycombing with interstitial thickening, and in bronchovascular type, we can see the bronchial wall thickening and bronchovascular thickening. So along with that, we'll have elevated levels of IgG or IgG4, and the autoantibodies of ANA and RF may be positive, and on biopsy we can see lymphoplasmacytic infiltration with fibrosis. So this case has been already discussed. The patient with history of renal cell carcinoma. So yeah, it's Burt-Hawk syndrome. So Burt-Hawk syndrome, the classic imaging features are subpleural cysts. The cysts are usually paramediastinal and periphyseal. They are lower zone predominant, usually bilateral, and these cysts can show lobulations and septations, and they can also rupture to cause pneumothorax. So the diagnostic criteria for Burt-Hawk syndrome involves 1 major criteria and 2 minor criteria. So 5 adult onset fibrofolliculomas or pathognomonic FLCN mutations are major criteria. The lung cysts, the bilateral renal carcinomas, the chromophobe or oncocytic histology, or the first degree relative with Burt-Hawk syndromes fall under minor criteria. The 3 important differentials for cystic lung diseases are LCH, LAM and LIP. So LCH, I'll give you a set of points for differentiating each. So in LIP, it is usually associated with Sjogren syndrome, and it is more mid and lower zone predominant with thin walled cyst with interstitial thickening and nodules. So coming to LAM, usually the cysts are uniform sized and diffusely scattered. It is associated with tuberous sclerosis, and we can also see multifocal micronodular pneumocyte hyperplasia, which is seen as multiple tiny nodules. Usually these nodules are less than 10 mm in size, and we can see chylous effusions with pneumothorax. And then we have LCH. LCH is upper zone predominant. The cysts are usually bizarre in shape, and it usually affects young adults with history of cigarette smoking. And these cysts generally tend to spare the costophrenic angles. So this is a companion case where we usually we do not see this often. This is also a DD for cystic lung disease. Anybody? What do you see? Here's a tracheal nodule with multiple cysts in both lungs. Yeah, this is a case of tracheopulmonary papillomatosis. It is of 2 types, the juvenile form and the adult form. So adult form is usually confined to the larynx, but in case if you go ahead with the laryngoscopy or any procedure, these fragments tend to exudate into the lung, and then the lung cyst get formed. So this is another important differential for cystic lung diseases. So a 60-year-old male presenting with bronchoria. Define the sign and its significance. What is the sign seen here? You can see an enhancing vessel within a consolidated lung. So this is CT angiogram sign, which is where we can see a normally enhancing pulmonary vessels within the low attenuating consolidating lung parenchyma related to the chest wall musculature. The low attenuating component represents consolidation of the lung parenchyma, which can be caused by production of mucin within the air spaces. The sign was initially described as specific for lobular bronchoalveolar carcinoma, but it can also be seen with conditions like pneumonia, pulmonary edema, obstructive pneumonitis, lung tumors and lymphoma. So this is the next case, a preterm neonate with respiratory distress. Preterm neonate respiratory distress at birth. There is only one diagnosis for this case. So, yeah, this is ARDS. So how do you differentiate it? What is the grading of ARDS? Anybody? So grade 1 is when you see fine homogeneous ground glass opacities in both lungs. When you see widespread air bronchograms in both lungs, it falls under stage 2. And stage 3 is when the consolidation becomes confluent. And stage 4 is when there is alveolar opacities which obscures the cardiac border. So here another important image given here is lung ultrasound. Dr. Rajkumar has already explained about lung ultrasound. So lung ultrasounds, the normal lung ultrasounds can show A lines. A lines are nothing but reverberation artifacts which are reflections of pleura, which is normal. When these normal reflections are lost, it is called B lines. B lines are due to interstitial edema. So when the disease progresses, the interstitial edema also increases and the B lines tend to get coalesced with each other. These are called compact B lines. And next stage is consolidation. So how does a consolidation look in lung ultrasound is heteroechoic area in the subpleural location with multiple hyperechoic foci seen within. This hyperechoic foci are nothing but the air bronchograms which we see in CT and X-rays. So here is a case where there is a case of 1-year-old child with shortness of breath. Anybody? Diagnosis? So we can see a heterogeneous mass occupying the entire hemithorax with mediastinal shift. So within this age group, the most common differential for this is pleuropulmonary blastoma. It is of three types. Type 1 is it can be single or multiple cysts. The DDs for this include CPAM, large bronchogenic cysts, etc. Type 2 is mixed type. Type 3 is solid. And for type 2 and type 3 pleuropulmonary blastomas, the differentials include neuroblastomas and PNETs. These tumors generally do not invade the chest wall, and pleural effusion and contrasternal mediastinal shift can also be seen. So this is the next case, a 30-year-old male with recurrent infections. So what do you see here? Heterogeneous area of consolidation with a systemic blood supply. So what is the type of sequestration here? Intralobar or extralobar? So you can make the diagnosis just with the age. So if it occurs in an adult, it is always intralobar. Extralobar sequestration occurs in neonates. So these are the basic differences between intralobar and extralobar sequestration. So intralobar, both intralobar and extralobar tend to occur left side in the lower zone, but the left side of the lung is more affected in the extralobar type. Extralobar type is mostly affected in the neonatal age group, and intralobar presents in the adult group with recurrent respiratory infections. And the major difference in both is intralobar is usually the venous drainage is through pulmonary veins, where in the extralobar type it is from the systemic veins. So here is a post-COVID patient with productive cough. What is the sign and diagnosis? It's a spotter. Yeah, it's a bird's nest sign. What's bird's nest sign? It is nothing but a modification of reversed halo sign, where the central ground glass opacity has intersecting septa within. So it is specific for pulmonary fungal infections. This sign can be also seen with vaginous granulomatosis, bacterial pneumonia and pulmonary infections. So patient with history of trauma, the diagnosis, types and imaging features of pulmonary parenchymal injuries. So post-trauma patient, we have a cystic area with surrounding dense consolidation. So always we give the diagnosis of pulmonary laceration with surrounding contusion. So what are the types of pulmonary contusions or pulmonary lacerations? So there are 4 types of pulmonary lacerations. This was taken from radiographic articles. So the type 1 laceration is compression rupture type, which is due to sudden compressive force to the chest wall. So this occurs in the central lung and the deep portions of the lung. Type 2 is compression shear wave type, where there is a direct blow to the lung. The paravertebral lung parenchyma gets compressed with the adjacent rigid vertebra. So due to this, the laceration occurs in the paravertebral region. This is type 2 laceration. And type 3 laceration is when rib penetration tear occurs. So usually when we see rib fracture with associated subpleural cystic area, it is type 3 laceration. There is another type of laceration which is type 4. It is very uncommon. It occurs when there is previous iatrogenic history of pleuropulmonary adhesions. So these are the imaging manifestations of chest trauma. The pulmonary parenchymal injuries are usually contusions, lacerations, hematoma, and hemothorax and pneumothorax also occurs. So here we have a patient with antiretroviral therapy and HRCT chest was done. So what is the feature here and what is the diagnosis? So we see flame-shaped consolidations which are bilaterally symmetrical. Diagnosis, anybody? So it is a case of Kaposi's sarcoma. Kaposi's sarcoma is one of the AIDS-defining illness. So in Kaposi's sarcoma, the patients have usually bilateral symmetrical flame-shaped consolidations with surrounding ground glass opacities. The distribution is usually perilymphatic and peribronchovascular distribution, and they usually have high attenuation nodes, and pulmonary Kaposi sarcoma tend to occur when the CD4 counts are less than 200. Any other finding when CD4 counts drop less than 200 in a HIV patient? Yeah. So PCP is also an important differential when CD4 count drops less than 200. So AIDS defining neoplasms are non-Hodgkin's lymphoma, Kaposi sarcoma and cervical carcinoma. This is also often asked in exams. And when talking about PCP pneumonia, the typical features are perihilar with nematoceles and subpleural sparing. These are the 3 important points to remember when you talk about PCP pneumonia. So here is a case where you have a chronic kidney disease patient with hemodialysis who developed fever and chills and rigor. CT chest was done where we can see multiple cavitating lung nodules. Yeah, septic emboli. What is the sign seen in septic emboli? Yeah, feeding vessel sign and septic emboli. So for diagnosis of septic emboli, the clinical feature is the most important criteria. And the differentials for septic emboli are necrobiotic nodules in rheumatoid, vaginous granulomatosis, and cavitating lung mets. Any differentials for cavitating lung mets? So anyway, cavitating mets, the first differential should be squamous cell carcinoma, and also it can occur in transitional cell carcinoma of bladder and colon carcinoma. So here there is another case where the 31-year-old gentleman presented with burns and plastic surgery OPD with scars in the left side of the neck. So this history shows that he has some neurovascular problem and the associated burn contractures are also present. So the X-ray and CT findings are given. Diagnosis? So you have a fat density center with peripheral calcification and consolidation. So it is lipoid pneumonia. So what are the types of lipoid pneumonia? So lipoid pneumonia can be endogenous or exogenous. Exogenous lipoid pneumonia can be of 2 types again, acute and chronic. So acute lipoid pneumonia is always seen in children with poisoning and also in fire blowers where they tend to ingest petroleum based products. But another type of exogenous lipoid pneumonia is chronic type, which is seen in chronically bedridden patients due to chronic aspiration of animal fats. So and due to this, there is a characteristic finding which is a fat density center. The presence of this fat is highly characteristic for lipoid pneumonia. And exogenous lipoid pneumonia is also called paraphenoma. So patient presenting with chronic cough and the patient is COVID negative. Any other diagnosis? Peripheral subpleural ground glass opacity. if I say the serum eosinophils are elevated, so this falls under eosinophilic lung disease. So the eosinophilic lung diseases can be classified as simple pulmonary eosinophilia, acute chronic hypereosinophilic syndrome, and eosinophilic bronchitis. So acute eosinophilic pneumonia, the diagnosis is very important because it presents with a very acute presentation of fever and chillness, and if it is diagnosed immediately and treated with steroids, it has 100% cure rate. So it is not like always the fever with subpleural ground glass opacity is COVID. So have a differential of eosinophilic pneumonia in mind. So in acute eosinophilic pneumonia, the serum eosinophils are not always elevated. So for the diagnosis of acute eosinophilic pneumonia, you have to go ahead with the bronchoalveolar lavage and prove the eosinophils within it. Whereas in chronic eosinophilic pneumonia, the serum eosinophils will be elevated. So what is hypereosinophilic syndrome? So hypereosinophilic syndrome is chronic eosinophilia with multi-organ dysfunction. It can affect both heart and lung. So the primary involvement will be mostly in the heart. In heart, the characteristic finding is endomyocardial fibrosis, where we can see late gadolinium enhancement in MR, and due to the cardiac failure, we'll see pulmonary edema in lung. And eosinophilic bronchitis is a rare phenomenon where we can see bronchial wall thickening and subtle nodules. And eosinophilic lung disease, a chronic eosinophilic lung disease, upper lobe predominance with reverse bat wing appearance, where the subpleural lung is more affected. The DDs for reverse bat wing opacities are organizing pneumonia, pulmonary contusions, and hemorrhage. Thank you.
It was a pleasure listening to you, sir. It was such a thought-provoking session. Now I request Dr. Subramani sir to facilitate Vijay Thiraviyam sir.